Hello, good afternoon, and a warm welcome to this afternoon online session, which is powered by Icona Health and Research Consult. I am happy to be your moderator for this online session, together with my own brother, Michael Adu Abuaji. Without wasting much time, I would like to introduce our facilitator for today's program. Of course, her first slides talks about it all, but let me dive deeper into talk about our facilitator. She is in the person of Madam Mary Agoriwo. She is a lecturer at the Department of Physiotherapy and Rehabilitation Sciences at UHAS, who, for her educational background, she graduated in 2010 from the University of Ghana with a bachelor's degree in physiotherapy and also obtained a master's degree in neurorehabilitation in 2017 from Brunel University, London, in the United Kingdom. Currently, she is a PhD candidate at Stellenbosch University with the Faculty of Medicine and Health Sciences, Cape Town, South Africa. With her work experience, Madam Mary has practiced physiotherapy at the 37 Military Hospital on internship basis and at the Kolebu Teaching Hospital for 10 years prior to her joining University of Health and Allied Sciences in 2020. She also served as a guest lecturer in rehabilitation and Parkinson's disease, a clinical supervisor and examiner to the physiotherapy and occupational therapy students of the University of Ghana, Legon. She has expertise in management of all physiotherapy-related conditions, but specialized in care and neurological conditions with interest in movement disorders, especially Parkinson's disease. Mary coordinates the activities of the Parkinson's disease support group in Ghana, a non-governmental organization that is aimed at providing support for people with Parkinson's disease and their caregivers. Currently, she teaches, conducts research, and provides outpatient physiotherapy services to people with neurological disorders, mostly Parkinson's disease. In September 2014, she was sponsored by the International Parkinson's and Movement Disease Disorders, that's the MDS, as one of the only 2 African delegates to attend a course on the management of Parkinson's disease in Portugal. Upon her return, she led the Parkinson's disease team in organizing its maiden Parkinson's disease forum, which provided education to PD patients at the hospital and also to the caregivers and the public. This initiative created the opportunity for Parkinson's disease patients to interact and share the ideas. Mary is a Chevening scholar. She is also part of the GPA evidence-based practice research group. For her information, she is also an award recipient for the recent World Physiotherapy Congress that was held in Dubai. For the award, she presented on compliance and barriers to physiotherapy among patients with Parkinson's disease at the Kolebu Teaching Hospital, which was an explanatory mixed method study. For her research and science outputs, her interest obviously is in Parkinson's disease, aging, and age-related neurodegenerative diseases. Currently, she is a member of the UK-Ghana Marathon Project, a collaborative study between the University of Southampton and the Kolebu Teaching Hospital, which is in charge of the Parkinson's disease research team. She also presented at the National and International Conference on Rehabilitation in Parkinson's disease and facilitated numerous workshops on Parkinson's disease, aging, and neurodegenerative diseases, and has been part of the development of the COVID-19 rehabilitation guideline for Ghana and Africa. At personal level, Madam Mary has been my lecturer from UHAS, and through her influence, I also joined the International Parkinson's and Movement Disorder Society. If you ask me to use just one word to describe Madam Mary, I will say she is a human. Ladies and gentlemen, I present to you Madam Mary Agoriwo, our facilitator for today's program.
Thank you very much, Ibrahim, for that comprehensive introduction. I would have wished it was a bit shorter, but that's fine. So let me show my video briefly, then when I'm done, I will put it off. So as introduced, I'm Mary Wetane Agoriwo, and I will be facilitating this evening's session. So as it's indicated on our flyer, we are going to look at clinical assessment in Parkinson's disease with a focus on physiotherapy. So everything we are going to talk about today is about assessment. Parkinson's is very broad. It has a lot of branches, and this is just one small aspect of it, which in itself is not that small, because without a good assessment, you will certainly not be able to provide good treatment or rehabilitation service for persons with Parkinson's. So let us focus on how best we can assess a person with Parkinson's, and then in future, we can look at how best we can help persons with Parkinson's live a good life without serious complications or without a lot of limitations and disabilities. So join me and let's go through the few slides I have here. Let's be interactive. I think I will keep it open. If at any point in time you want to seek clarification, kindly stop me and then do so as we go on, so it becomes as interactive as possible. So I will put off my camera so we can all focus on the slides. Thank you very much. Okay, so this is a brief outline of what we will be looking at this evening. An overview of Parkinson's. We can certainly not talk about assessing the condition when we do not know what it is. So it is very important that at least if even we know something about it, we remind ourselves of what it is, so we can have a fresh picture of what Parkinson's looks like. Then we can proceed into the assessment. We still need some little reminder on what the prevalence is, what causes it, if only there is a cause, the signs and symptoms of it, the classification, and then we zoom into our clinical assessment. And at the end of this session, at least everyone present should be able to describe what Parkinson's disease is. If you see someone with Parkinson's, at least there should be something to prompt you that this looks like Parkinson's. Then we can do further assessment or examination to confirm if truly that is it. and one should be able to identify the signs, complete a physiotherapy assessment of a person with Parkinson's, and we will be focusing on the ICF and then the WHO package of intervention for rehabilitation. And then when we talk about assessment, we cannot do so without appropriate outcome measures. So by the end, you should be able to pick an appropriate outcome measure that is required for a particular assessment that you have to do. So when we say Parkinson's disease, what is it? It's a complex neurodegenerative condition with a progressive loss of dopaminergic cells. And these cells are located within the substantia nigra, which is the midsection of the brain. And there is also the accumulation or deposition of what we call the Lewy bodies. And these are pathological proteins. So when we scan the brain or we look at the substantia nigra aspect of the brain, you realize that there are few cells there. That is the dopaminergic cells. If you look at this picture we have here, you will see that in a normal person, we have a normal quantity of these neurotransmitters, and that is the dopaminergic cells. They produce the dopamine that is responsible for the communication, the normal movement that we see in human beings. So when these cells are kind of degenerated, then we are left with few of them. When it is few, automatically it produces less dopamine. And in the case of someone with Parkinson's, this is how it looks like as we see it below here. These balls here are just to represent the cells. And when you look at the midsection of the brain that has been opened up, you will see that in a normal person, this side is darkened, that is the substantia nigra, where the dopaminergic cells are located. This darkened part is an indication that this is normal and we have all the cells there. However, in someone with Parkinson's, you realize that the side is quite faint. This side is faint. You don't see it as dark as the person without the condition. And this tells you that there has been some kind of degeneration to the dopaminergic cells here, resulting into the signs and symptoms that we see in a person, and then we can describe that as Parkinson's disease. So basically, before a person will exhibit these signs, there should be this degeneration in the dopaminergic cells. And as it states, it's progressive. So once it starts, it doesn't end. It goes on and on and on. And anything that will slow the process is not about stopping it, the degeneration. It will still certainly go on, but other things will help maintain the person's quality of life and level of activity. So PD remains the fastest growing neurological disorder in the world. This is looking at it broadly. This is neurodegenerative and it falls under neurological conditions as well. And it is fast growing. Day in, day out, the prevalence numbers are increasing over the years and then in the worldwide. There is over 100% deaths and 80% disability adjusted life years that resulted from PD since 2000. So since the year 2000, when we look at the number of persons that died, the number of persons who had some form of disability from diseased conditions, that of Parkinson's is over 100% compared to the numbers we had in 2000. And this assessment was done in 2019. So all the way from 2000 to 2019, when we look at these figures, that of PD is over 100% what was recorded in 2000 and over 80% disability. So persons with Parkinson's end up with a lot of disability that affects their quality of life. And that should give us a cause to worry. Then it is the second most common neurodegenerative condition worldwide, And this is after Alzheimer's disease. In Ghana, because we are talking from the Ghanaian setting, we should know how Parkinson's looks like in our environment. Is it towing the line of what is happening in the world, or Ghana is spared? Unfortunately, we are not that spared, because Parkinson's stands as the third most common non-communicable disease after stroke and epilepsy. And this is a study that was conducted at the Confanochi Teaching Hospital, the adult neurology unit, and that is what came up. At Kolebu Teaching Hospital, it is the top hypokinetic movement disorder. So considering all the number of or different movement disorders that were recorded at the Kolebu Teaching Hospital Adult Neuro Clinic, Parkinson's was number one, with all the attendant disability and problems that you could think of. So this tells us that we have every reason to pay attention to Parkinson's as a neurodegenerative condition, because as the aged population increases, now we are blessed with long life because of good healthcare system and all that. People are living longer, and PD is associated with aging. So we need to pay attention, and with these figures, we have to pay attention to how we manage it. In terms of causes, we do not know what caused Parkinson's disease, so we describe it as an idiopathic condition. However, there are some conditions that will present with Parkinsonian symptoms or signs. So when you see them, they look like an idiopathic Parkinson's disease. However, there is an underlying cause. So for instance, someone with a brain tumor, depending on where the tumor is located, from the earlier slides, you realize that it is the midsection of the brain, that is the substantia nigra, that is where the problem occurs. So if someone should have a brain tumor around this area, it's going to disturb the dopaminergic cells, and that will result in symptoms that look like Parkinson's. And we refer those ones as what? Parkinsonisms. So they are not the typical idiopathic Parkinson's disease, but are Parkinsonism because they have an underlying cause. And in some instances, when the underlying cause is removed, then you get the person improving in terms of health-wise. Stroke can also cause that. We call that vascular Parkinsonism. So we know stroke has to do with also brain damage as a result of short blood supply, whether being a hemorrhagic or infarctive stroke. So it also depends on which part of the brain is involved. Some viruses can cause that. Some toxins, exposure to toxins, could also cause these Parkinsonisms. And then some drugs. So for instance, someone suffers from a particular condition and is being put on any of these medications, it could trigger some of these Parkinsonism symptoms. In such situations, when the medications are withdrawn, the condition is likely to improve. Then tumors in the basal ganglia. Parkinson's, mostly the basal ganglia is severely affected. Our movement is being controlled mostly by the basal ganglia. And because communication at that point is affected, certainly it results in all the problems that we see. Most of the movement problems we see comes as a result of the disturbances in the basal ganglia. So any tumor in the basal ganglia can also present some symptoms that will look like Parkinson's disease. Then hydrocephalus could also cause that. We have the hemi-Parkinson hemiatrophy, also an atrophy within the brain that can result in Parkinsonism. Now, with the symptoms, we look at the motor symptoms. In Parkinson's, by the time the degeneration reaches about 60 to 80%, then one begins to exhibit the motor signs of Parkinson's disease. So the degeneration will start gradually. By the time one has lost about 60% of these dopaminergic cells within the substantia nigra, then the person begins to exhibit the motor signs of Parkinson's disease. And we have the cardinal motor signs that when you see these particular signs, then it should trigger you to think that this is a likely Parkinson's disease. Number one is bradykinesia, which has to do with slow movement. Once we say brady or akinesia, a means like the absence of the movement, and brady is slowness. So the person moves slowly, and sometimes because most of these patients are elderly, we sometimes think, oh, it's part of aging. The elderly person walks slowly, but there is some level of slowness that tells you that no, this is not normal slowness, and one will have to look into it. Then also we have the resting tremor. You see the hands shaking. It could also be the legs. It is not limited to either just the hands alone or the fingers alone, but the leg too sometimes shakes. And with the resting tremor, the person doesn't need to move. I was thinking of showing a video, but because it's a live streaming with ethical issues, I'm not able to do that. So forgive me for that. Else I would have shown the resting tremor for you to see. But it's just about shaking. In simple terms, that's how we would describe it. Then rigidity. Rigidity is about tightness within the muscles. So when you feel the muscles, it doesn't feel normal like every other person's, like a normal muscle, but feels a bit hardened. And then when you move the joint, you realize the movement isn't smooth. Sometimes it feels a bit jerky in it. So to test for this rigidity, you just have to move the elbow gently. And this is done passively. And when you move it and you don't get that fluid movement, that is normal for every other normal person, then that tells you that there is a problem with the muscles as well. They feel tight, and we describe that as what? Rigidity. So these three key signs are what would tell one that, oh, okay, there is something in there that should prompt Parkinson's. In the very early days, the number one sign was resting tremor. Then any of these signs could then confirm that indeed, and then the person responding to the levodopa then confirms that indeed we are dealing with Parkinson's disease. But as time went on, it was realized that other conditions also presented the tremors, because we have the essential tremors as well. We have the intention tremors. And with Parkinson's, it gets to a point where even when the person is moving or is about to do something, you still see the tremors. So you get both the resting intention all put together. So gradually, we shifted from the resting tremor as the key sign to bradykinesia, which is very limited to Parkinson's disease. So it is the slowness first, then any of these two, and then the patient responding positively to the levodopa or the PD medications. Then we can confirm that indeed we have Parkinson's disease to manage. Then also we have postural instability. This has to do with issues with loss of balance and then posture. This has also been part of the cardinal motor signs, 4 of them. But the caveat here is that when postural instability occurs very early in Parkinson's, early here means within 1 year of diagnosing Parkinson's, if postural instability becomes a problem or balance becomes a problem and the patient begins to fall, then we should be thinking of something else rather than Parkinson's disease. And an example of the something else we could think of is multiple system atrophy, which will also begin to present something like Parkinson's. then we might begin to treat as Parkinson's. Once the false postural instability becomes a rare problem in the very early days, then we should be thinking of multiple system atrophy. But in our side of the world, most of the times, by the time the patient even gets to the hospital for even the first assessment, the person has lived with the condition for like 2-3 years before they are coming to the hospital. So by the time they come, they're already presenting this postural instability as part of the key motor signs. So just take note of this. So this is one simple way of describing this cardinal motor signs. We call it TRAP. So the tremor, the rigidity, the akinesia or the bradykinesia, posture, and then balance issues. There are other motor signs with Parkinson's, and as we can see in the picture here, we have stooped posture as well. We have the maxed face, you have the trunk tilting forward, a reduced arm swing when they walk, they have flexed knees, and then there is shuffling gait. When they take short steps, that is what we call the shuffling. Then the festinate and freezing comes as time goes on. So the other motor symptoms as listed here, the loss of arm swing, the stoop posture, reduced facial expression, walking difficulty turning in bed, and then one other major problem that they complain of is what we call the micrographia. So when they write, the writing becomes very small. So this can be likened to their walking, the steps they take. As they walk, even when they begin with long steps, gradually as they go on, you realize that the steps become shorter and shorter. So the same thing principle applies to the micrographia. So when the person begins to write, they write with the normal size of the letters, keep writing. In the very severe cases, the sentence ends up in something like a line that you can't even see the words that they have written. Now, aside the motor symptoms, persons with Parkinson's also present with non-motor symptoms. And these are very disabling. But because we mostly don't see them, we are tempted or likely to overlook them. But they are really troubling problems for persons with Parkinson's. And these mostly affect their quality of life as well. One of them is what we call the sleep disorders. So early awakening, they are not able to sleep. When they fall asleep, within a short time, they are up, they open their eyes, they can't sleep again. Then in the daytime too, you see them sleeping too much. And all these things are non-motor symptoms that come with Parkinson's disease. We have the neuropsychiatric disorders, so many of them: depression, anxiety, apathy, cognitive deficit, mood disturbances. All these things come in. Parkinson's is such that most people who suffer it end up with these neuropsychiatric disorders. I came across one patient who was kind of more anxious, with this apathy, not interested in anything around him, and was just not positive. And all his challenge was that he has suffered so much in life. He has worked so much in life. He just retired, and he felt that is the time he was going to rest and enjoy his life, only for disease to come across his way. And he just couldn't accept the situation that he has to now begin to battle in this phase of his life where he felt it was a resting moment. So such a person is likely to even drift into depression if care is not taken. And these are things that really affect their quality of life. Autonomic dysfunction, such as dizziness, urinary or bladder problems, orthostatic hypotension. So the person goes to a function, sitting down, wants to go to the washroom. Once they get up, they just faint and fall to the ground. So much embarrassment. After they are being put down for a while, they are okay. And it's just because of this orthostatic hypotension, the blood pressure dropped with a sudden rise like that. Then we have gastrointestinal disorders to constipation, drooling. Their swallowing also becomes defective. The ability to swallow becomes defective. Initially, we thought persons with Parkinson's were producing too much saliva compared to someone without the condition, but later research revealed that it's not about producing excessive saliva, but it is the difficulty or inability to swallow as frequently as every other normal person would do. As I'm speaking, naturally, I produce saliva in my mouth, so my mouth doesn't get dry. But as that saliva comes up, I have to also be swallowing. And this is not something you consciously do. It's an automatic thing. As it comes, you are swallowing. As it comes, you are swallowing. In the case of a person with Parkinson's, it's not as simple as such. So as they sit, they are not swallowing, and the saliva now pools in their mouth. And that is where you see the drooling or the dripping of saliva with persons with Parkinson's. In the issues of constipation also, the same rigidity that happens in the muscles, the same thing happens with internal organs as well. And we know the intestines all the way to the rectum, all of them are also muscles that make up all such organs. And there should be that peristaltic movement in there to facilitate the movement of the bowel content. But if rigidity is happening in the muscles we can touch outside, same thing is happening in internal organs, then it affects that motility within, and that results in constipation among most of them. So this is also something that really troubles persons with Parkinson's. So we have to pay attention to this. In as much as we are physios, our focus is on the physical. If your patient is troubled with all these non-motor symptoms, I bet you will not make progress with your physiotherapy. So we have to pay attention to them. Sensory symptoms are as pain. Yeah, it's one of the key things that persons with Parkinson's will complain about, and our signs will tell us once the muscles are tight, joints are not moving freely as they should, certainly the joints will develop some pain, and that we need to pay attention to. So the MPS has also described what we call the prodromal factors. And these prodromal factors are mostly non-motor symptoms. So they have even designed a web-based calculator called the prodromal PD calculator. If you key in certain responses, it shows whether a person has prodromal Parkinson's disease. And this is the non-motor phase, meaning at that point, the neurodegeneration, the degeneration of the dopaminergic cells are ongoing, but maybe it has not reached that 60 to 80%, which would trigger or prompt the motor symptoms for one to now see that indeed something has gone on wrong within the brain. So these factors, the olfactory dysfunction, loss of the sense of smell, constipation. Now with COVID, which is also causing loss of smell, one will have to be careful how you want to think that people are likely to develop Parkinson's. And then constipation, excessive daytime sleepiness, depression, urinary dysfunction, erectile dysfunction, symptomatic hypotension. That's the same as the orthostatic hypotension. So you see that all these are non-motor symptoms. However, studies have revealed that persons who ended up with Parkinson's disease, most of them had these symptoms like 10 years back before they had the Parkinson's. So this is what we call the prodromal Parkinson's disease, or the prodromal stage of the condition. at the point where the neurodegeneration is ongoing and the non-motor aspect, the autonomic function within the system is being affected. But because it's non-motor, one doesn't worry so much about it until the motor signs begin to add up. And these prodromal symptoms do not go away. When the motor symptoms begin to show up, they still run along with the motor symptoms and then even worsen as time goes by. Now, as the disease progresses, we end up with some motor complications. We have postural instabilities, we have falls, we have freezing of gait, we have the dyskinesias, involuntary muscle movement, loss of voluntary movement completely, involuntary muscle contractions with twisting and repetitive movement. So when it gets to this point, for the dystonia part, once it gets there, even medications can't help. At this point, the solution is deep brain stimulation. And that is what has proven to help resolve these dystonias in persons with Parkinson's. So with these complications, what we wish is that we start rehabilitation very early so we can at least slow down the progression of the condition so the patient doesn't get to these complications very early in the disease journey. Now, how do we classify Parkinson's? The classification is based on the stage of the condition or the age at which a person is diagnosed. So with the stage, we go by the Horn and Yahr staging of PD. It's 5 stages. There is another approach to the staging, but that is a pathological approach to staging. It's about 7 stages. But we want the physical ones that we see, because for physios, we relate more with the physical stuff. Even in the assessment process, is the physical one that we need to inform the kind of intervention we give. So in the early stage, where we have the Horn and Yahr stage 1 and 2, the very early stage where tremor starts, and then in one limb. So this limb is not just the upper limb alone. Like I said, it could also be in the lower limb. Then activity at this point is normal. The person can do every other thing like every other person. So hardly do you see persons in the clinic at stage 1, hardly, because at this point, it doesn't bother activity. So they will want to manage. And maybe they don't even know that this is a sign of something big ahead. So let me take earlier steps. They don't know. So by the time they get to you, maybe they are in stage 2, where symptoms have now progressed to affect the other limb. So that is the rate or the pattern of progression of Parkinson's. It doesn't start on both sides the same. So when symptoms begin bilaterally, we should be thinking of something else rather than Parkinson's. Parkinson's will always begin unilaterally. It doesn't matter whether it's an upper limb or a lower limb, it starts unilaterally. So it affects one limb first, then gradually it progresses to involve the other. Now, walking becomes a problem. And then also daily activities also becomes difficult to complete, and the person easily gets tired. In the stage 3, which is the moderate stage, you have severe symptoms with inability to walk straight, and this is where you begin to see the obvious stoop posture of the person. Things begin to become very slow, and there might be likely falls. In the advanced stage, where we have stage 4 and 5 in here, symptoms have now become very severe. Muscles are extremely tight with the rigidity, and the person becomes extremely slow. They might become bedridden or wheelchair bound and will require one-on-one nursing care. For strange reasons, the tremors may disappear. It's been recorded in a number of cases like that, where the tremors disappear for unknown reasons. As we speak, we don't really have interventions specifically targeting the tremors, but there are few techniques that one will do to reduce the effect of the tremor. With regards to the age, we have the juvenile Parkinson's disease, which affects people below 21 years. The young onset affects below 60 years, but mostly between 21, 40, going to 50 years. And then the adult onset from 60 years going. Then we have the adult onset. So majority of persons with Parkinson's are adults, the adult onset. So from 60 years upwards. And that is why sometimes it is confused with normal aging and the patients do not seek early health care. Now, when we come to our clinical assessment, because Parkinson's is a neurological condition, we will be saying we are doing a neurological examination or assessment, which is when we assess the sensory neurons and the motor responses to ascertain whether the nervous system is functioning properly or there is any impairment to the nervous system. And that is it about neurological examination. And this will include a review of the patient's medical records plus a physical examination. So in this neurological assessment that we do, it could serve as a screening tool or an investigative tool. One might ask, what is the difference between screening and then investigation? Most of the times you hear that, oh, we are going to do screening. And over there, we check blood pressure, we check sickling status, we check sugar and all that. For instance, if we check sickling status and we realize that there is positive, we have screened and it has come out as positive. We now need to do further examination, and that is where the investigation comes in. You do further tests, further scans to actually confirm that indeed the person is sickle cell positive and it is this either the SS or the SC or the various categorizations in there. So that is it. You can use it to check whether there is a sign of Parkinson's in there. And if truly it is there, you need to now do the investigation to confirm the Parkinson's and then rule out other things. Now, for us to do a very comprehensive assessment, it is better we fall on the ICF framework. And this gives us the perspective of looking at the condition, the person in relation to their environment. So before we make progress, I want us to do something quickly here. And I want Ibrahim to help me with this. So it's a communication between a physiotherapist and his patient, Mr. Kujo. This is an arbitrary name that I picked. So I will take the position of the patient and Ibrahim will take the position of the physio. So kindly, let's go. So Ibrahim, please go. You are the physio.
Mr. Kojo, how is your home X going? Are you able to do the daily works as I advised?
I tried a few times, but I stopped. Sincerely, I haven't been doing the walking.
It's been 3 weeks now. So, what is the challenge?
I live in a compound house with about 7 other tenants. The compound is usually busy in the mornings and evenings, and I feel a bit uncomfortable when they all look at me when I'm doing the walking. These are times where I really want to do the walking. I wish to walk. And afternoons, the sun is too hot too, so I'm not able to do it in the afternoon.
What of outside the compound?
It's very rough and I'm afraid to fall.
What of your room? Do you have about 2-meter long space?
Yes, it could even measure up to 5 meters.
Great. Can you do a bit of walking within the space in the room while we figure out how and where you could get a safe place outside to do more walking?
Sure, I will try. How I wish this issue came up earlier. Thank you, Ibrahim. Yes,
You're
so
welcome.
I just want to paint this picture as a discussion between a patient and the physio. Mostly when we see our patients, we give them home exercise. Or we say, when you go, do this, do this, do that. Sometimes we just say by word of mouth. Sometimes we don't even demonstrate for them to see. This PT has asked the patients to do some walking in the house. But the PT did not ask further questions about the convenience of this walking in the house, whether the patient even has enough space, comfortable space to do so. So 3 good weeks passed, and Mr. Kojo has not done the home exercises. If you are a good physio, you will certainly know if your patient is not doing his or her home exercises. So I believe this is a good physio who has realized that there is a challenge that Mr. Kojo has not been doing the exercises, and he probes further. And now it's obvious that Mr. Kojo doesn't do the exercises. And his problem is that, yes, he has the large space compound, all right, he could do the walking. However, he's not comfortable with the many people in the compound. Did the physio even ask the living environment of Mr. Kojo during the time of assessment? Did he ask how his outside, the internal compound looked like? I'm very certain the physio did not do that. If he did, this issue would have been addressed earlier, as Mr. Kojo said. He wished the issue came up earlier, so they had discussed the way around his discomfort. So now let's see how best we can carry out our assessment so we will be able to address all these things. And that is where the ICF comes in. So the ICF looks at a person's level of functioning as a dynamic interaction between his or her condition and then the environment, and then some factors of the person, himself or herself. So it uses the biopsychosocial model of disability. You know, there are a number of these beliefs, the social model, the medical model. The social model is based on, okay, you know where you got your disease from. The issue of maybe the person has gone to offend the gods. That's why the gods have struck him or her with this kind of disease. This is a disease with an evil hand in it, and that is the social model of disability. It's the condition is linked with some beliefs. And we have the medical model of disability. So the focus is just the disease that we want to deal with. We want to treat the disease, forgetting that the disease is sitting inside a human body. And that human body lives within a society or within an environment, which must be taken into account when you want to deal with that disease in the picture. So this is how the ICF framework looks like. We have the disease there, we have the body function structures, we have the activities participation, the personal factors, and then the environmental factors. So these factors put together are what we call the contextual factors. The context within which the person lives will have to be taken into account. So let's look at these specific components in details and how the disease is related to these components. So the disease we are talking about here is the Parkinson's disease. And looking at the body functions and structures. So this is body functions, body structures. What are the body functions? These are physiological functions of the body systems, the normal physiological function of the body. And psychological functions are also part of that. Then the body structures are the anatomical parts of the body. So if there is any problem with this function or the structure, we describe it as what? Impairment. So we have body function impairment and body structure impairment. And pain is a body function impairment. Stiffness is body function impairment. If we want to look at the structure, we are looking at a significant deviation or a loss. So the case of an amputated lower limb or upper limb becomes a body structure impairment because there is a significant loss of that body part. When we look at the deviation, if we have an elbow in a fixed flexed position or fixed extended position, that becomes the body structure impairment when we have a fixed flexed elbow, because there is a deviation in the normal body structure. The elbow is supposed to be mobile. You should be able to stretch and then bend it. If we are not able to do so within the normal limits that we know, then that becomes a deviation and it becomes a body structure impairment. Now, when we come to activity, what is the activity? It's just an execution of a task or an action. And any problem with that will lead to an activity limitation. So difficulty with eating, difficulty with toileting, difficulty walking, difficulty washing or taking your bath, all becomes what? Activity limitation. Then we have the participation. So participation is involvement in life situations. That is what participation means. And any problem with that becomes a participation restriction. So difficulty in taking part in communal labor, difficulty in going to church, difficulty in attending funerals, weddings, all becomes what? Participation restriction. When we look at the ICF, they have not really given that distinct definition or like separation between the activity limitation and participation restriction, because depending on what item you are looking at, sometimes it could act as an activity limitation or a participation restriction, depending on the focus of the action you are looking at. So if it is the individual just performing it, it becomes an activity limitation. If it involves other people, then it becomes a participation restriction. So this is kind of item specific for us to be able to describe whether it is an activity limitation or a participation restriction. Then when we come to the contextual factors, we have the environmental factors. And all these physical, social, attitudinal environment come together to form the environmental factors. So even the health professional's attitude towards the patient is an environmental factor. It could facilitate the patient returning to the clinic or not returning to the clinic. And this must be factored into it when we are managing a condition. With the personal factors, these are backgrounds of the individual's life and living that are not part of the health condition. So the person's demographic factors, their lifestyle, their coping style, habits, and upbringing says a lot about how a person is able to cope with life challenges. When a disease struck a person, we can't describe it as a life challenge. So for instance, this patient I made reference to, who had retired and has just been hit by the diagnosis of Parkinson's, how optimistic is this person in life? If he's a very optimistic person, then he knows that, well, this diagnosis is certainly not the end of the world. What are the options available in dealing with this diagnosis? I need to embrace life just as it is and see how best I can live my life, even with this condition. Get involved with other people so I don't get totally affected or consumed by this condition. But that isn't the nature of this person. He's asking questions and still in the state of denial. Then you have a whole lot of things coming in. If your patient is like that and you don't address that aspect as well, I tell you, you will not see progress with your physiotherapy because they will not be motivated to do what you are teaching them to do. They will not be motivated to take those daily walks that you might encourage them to do. So it's very important that we look at the patient as a holistic being and try to address all these components, even as we focus on our physiotherapy interventions. So now, in assessment, we look at the subjective part and then we move to the objective part. So with our subjective assessment, you need to take a detailed history of the condition. So if we say detailed history, what and what are you to ask? You need to ask appropriate questions, and this include the presenting complaints. When the symptoms started, the nature of the symptoms, the rate of progression of it, what aggravates or relieves the symptoms, how the disease affects the person's life or activities of daily living, what previous interventions have been sought, family, social life, and home settings. These are just key points I have listed here. Depending on the patient you have, you could ask other questions that will prompt you to include all these holistic aspects that the ICF framework describes. And at the end of the day, you would have done a comprehensive assessment on your patient to inform the interventions that you will have to do. So I've indicated here, by the time you ask all these, you would have been able to pick some information with regards to impairment, with regards to activity limitations and participation restrictions, with regards to personal and environmental factors. And all this put together will help inform the interventions that you will give. Now, when we come to the objective assessment,
you have to look at how to enhance
okay.
privacy.
Hello?
Patients and answers.
Yeah. Are you asking a question here? Okay. I guess this wasn't for me, but if you want to clarify something, you can come again and then ask your question. Thank you. Yeah. So looking at the objective assessment, this is based on observation and physical examination. So as I used to tell my students, the assessment doesn't begin when you have come to sit by your table and your patient is seated. No. Sometimes the assessment even begins right from the car park when the patient has dropped from his or her car or is about to drop down, if only you are available there to observe what goes on. Right from there, assessment begins. If you didn't have the opportunity to see that, the patient is already seated at the OPD, you call the patient, and as they are walking into your table or into the treatment area or assessment room, you need to observe and pick key things that you would then want to ask further questions on. So the assessment will be guided by the ICF and then the package of intervention for rehabilitation. This was recently launched by the WHO. Sorry about that. So we will focus on this to be able to do a comprehensive assessment. So just something brief on the package of intervention. It's looked at 20 health conditions and Parkinson's happen to be one of them. If you look at the statistics on the prevalence of PD that I gave, it is not surprising that PD made its way into this important literature that has been provided to support the information that we need for PD-specific intervention, assessment, the appropriate workforce that is needed in managing the condition, assistive products, consumables that are all needed to address the specific functioning problems that a person with Parkinson's has. So our focus here is the assessment. So we are not talking about the workforce, we are not talking about intervention, we are not talking about assistive products, but if any of them should find its way related, I will mention it briefly. But the focus this evening is on the assessment. So this slide here is just giving you an information on all the conditions that were included in this PIR. And like I said, our attention is the assessment of Parkinson's. So the first thing there is assessment of cognitive functions. And you know, once we talk about a neurological condition, something that has to do with the nervous system, we cannot leave cognitive function out of it. So we will need to find out long-term or short-term memory. And we have ways of doing this where you want to know where the person is at the moment. If you ask them and they say, I'm in my son's house, that tells you that there is a problem up there. But there are standard tools that we need when we do objective assessment. So as we go on, you will see a lot of outcome measures that I'll be mentioning as we move on for the specific assessments that we have to do, so that you can have that objective measure to base on to determine whether you are making progress or you are not making progress. So we need that objective assessment. So the mini mental state exam scale is one of the commonest cognitive assessment tools that one can make use of. Then also sleep function. We need to ask about sleep history, pattern of record, restless leg syndrome, and then what we call the REM sleep disorder in persons with Parkinson. So these sleep disturbances could be inability to fall asleep, inability to stay or difficulty staying asleep. That is where the early awakening comes in. They have difficulty falling asleep. When they sleep too, they wake up easily. Then daytime, they'll be sleeping too much. And then the restless leg syndrome is excessive movement of the leg. Like, it's so uncomfortable that the person will certainly have to, they keep moving like that. You find out about that. Then the REM sleep disorder too. When we sleep in the normal pattern, there is a phase within the sleep cycle where we call the rapid eye movement. It happens every 90 minutes when we sleep. When we are asleep, every 90 minutes, this REM phase of sleep comes up, where the eyes move rapidly. That is why it is called a rapid eye movement. During this phase of the sleep cycle, the muscle tone is kind of reduced. Some would describe it as the tone, the muscles kind of paralyzes in the limbs, the upper limbs and the lower limbs. It is a phase where one dreams. So the brain becomes active. If one should take an EEG of the brain, that is an electroencephalogram. If we should measure that, you realize that the brain will still be active as if the person is really active during the day and is linked to dreaming. So for persons with Parkinson, and this paralysis in the limbs is something that is regulated through the basal ganglia. And we all know that the basal ganglia is affected in the case of persons with Parkinson's. So they lose that ability. The paralysis of the muscle doesn't occur. Then the person begins to act out the dream. So if in the dream, he happens to be fighting with someone in the dream, in their sleep, they will be throwing their hands and legs, trying to punch the other person in the dream. So when you ask partners, they will tell you that their partners will be kicking them, will be punching them whilst they are asleep. And this tells you that they have that REM disorder. It is not in the scope, within the scope of a person with Parkinson's to manage this. But knowledge of all this has an effect on what we do as physical therapists, and we need to act. If it is a big problem, if the kicking is too much, then you certainly have to tell them to prompt their doctor, or if certainly someone with Parkinson's should already be seeing a neurologist. Sometimes they tend to tell us so many things because we spend much time with them. And if you ask, they will tell you. We are not speaking for our colleagues, we are speaking for ourselves. Just ask them if they have informed their neurologist. If they haven't, prompt them to do so. Mental health. We talked about this, we mentioned it as part of the science, so certainly we need to assess it. Depression and anxiety, refer this straight away if there are any signs or indications. The person is so withdrawn, they wouldn't want to talk, they wouldn't want to eat, they want to be locked up in the room. Once you ask and you get information on all these, please do refer them. Now, speech, voice, communication, and swallowing, as I mentioned with the drooling issue. The esophagus is made of muscle, so if we have rigidity, that is also affected. There should be some questions that will prompt the person's ability to, the speech, at least as you are talking with the patient, you are engaging them, you can conclude on that. And the swallowing too, if there is so much drooling, is obvious. It tells you there is a swallowing problem. Voice function, communication, the quality of the voice, intelligibility, communication skills, finding words, starting conversation, all these things you have to ask. But as you engage the patient, or most of these things come up. You ask the question and they are struggling to find the right words to communicate with you. Assessment of swallowing. All these you refer to the speech and language pathologist, but you will need to ask the questions to make a confirmed note that yes, indeed, that problem actually exists. Then you make a referral to the speech therapist. If you don't pay attention to it, you are likely to skip it. Now, sensory function, we assess for pain as well, and we can use the visual analog scale to do that. We assess urination, defecation function. This you ask about the frequency, whether there is any incontinence or issues of constipation. If there is incontinence, mostly you will see diapers and all that. So you need to ask about all this. Blood pressure, mostly when our patients come, we check their blood pressure. You check this patient's blood pressure and it's quite low. If even it's within normal, it could be high, whatever. Ask about sudden dizziness. If the patient is seated and then they rise up suddenly, do they feel any kind of dizziness that might cause them to fall? If you ask these questions, you will get to know if this orthostatic hypotension is an issue. then you can advise appropriately as well. Because if you don't ask this, they will not want to get up, feel dizzy and fall. So the home exercises you're asking them to do, they wouldn't do. Now we come to motor function assessment. This is more in our area. Assessment of joint mobility, range of motion. We have our goniometers to do this. And in this assessment, we can assess muscle rigidity as well, the tone. We know that to assess the tone, you will have to move a joint to actually assess the tone of a muscle. And this is done passively. Whether it is flaccid and you see that the joint is so loose when you do the movement, whether it is normal, with the normal tension within muscles, or it is hyper when it feels so tight. And like I said earlier, with the rigidity, when you move it, you feel that, what's the word that I used? It's kind of tight when you move it. I've forgotten what I used, or it feels, it jerks, yeah, within the range as you move. It doesn't move smoothly. And that tells you that the muscle is rigid. There is a hypertonic muscle in there. Assessment of muscle function, we are looking at muscle power or strength. We have the 0 to 5 scale of measuring the muscle power, which is 0 when there is no contraction. When there is a visible muscle contraction and no movement in the joint, we have 1. When it is there is movement in the joint, but not against gravity. So when you move a joint laterally, that is where we are grading at 2. If we are able to move against gravity with no added resistance, we have 3. If we move against gravity, but less than full ROM, then we have 4 with a little of resistance. Then if we move against full resistance with normal strength, then we have 5/5. So this scale of rating is something that I would say every physio is familiar with, and the same thing is applicable when we are assessing muscle strength for a person with Parkinson's. Now, other assessments that we could do to assess muscle function, we could use the 6 or the 6-minute walk test. We could use the time up and go test. We can use the functional reach test. The Beck balance scale is, we can also use that. And then the Unified Parkinson's Disease Rating Scale can also be used. Here you see that this is scored by the physician, because as part of their neurological training, this is something they go through. As part of physio training, we don't really go through this. However, there is still opportunity for a physiotherapist to learn how to administer this skill. So it's not rigid to a physician alone, but a physio, once you have trained yourself on how to administer this skill, you are good to go with it. Assessment of voluntary movement, whether there is difficulty with reaching and then transfers. In this assessment, we are looking at gait. So if the patient is walking, what and what are we looking out for in that gait that can affect the person's activity? So we are looking at the body and the extremity posture. Persons with Parkinson's have stooped posture, flexed trunk, elbows, knees are flexed. We have what we call the anticolis, the camptocomia, and then the PISA syndrome. All these are complicated postures that persons with Parkinson's end up with. If we do not manage them appropriately from the onset, they end up with all these complications. We look out for their walking speed, and that is where we will note the fascination of gait. The step length, the stride length, the cadence rhythm, that the number of steps they are taking. The base of the gait is also very important. Persons with Parkinson's usually walk with a narrow base gait. And then the arm swing and gait-related balance capacity. When they are turning, how stable are they? So when we talk about gait assessment in Parkinson's, this is what it entails. And this might not just be for Parkinson's alone, but even for other neurological conditions. If you are assessing gait, you have to look at the quality of all these components in them, and then you score them appropriately based on the outcome measure you are using. So other aspects of the voluntary movement, we can use the movement function. So the Unified Parkinson's Disease Rating Scale can also be used here. The freezing of gait questionnaire, the functional mobility, we could use the timed sit to stand, chair transfers. All these can be used to assess voluntary movement in persons with Parkinson's. But you can't do without the gait. That gait assessment is number one. You have to check all these and then indicate the quality of the patient's movement. So this is how camptocomia looks like. It is flexing at the waist level. So you see that if you look at C, the C here, the trunk is straight in here when the patient faces the wall like this. When they lie down, it's straight. But once they stand, they are not able to straighten up. It's because the muscles are not strong enough to be able to go against gravity to keep the trunk in an upright position. So thus, the muscle strength in the trunk has a problem, and we have to focus on working on it before it takes a structural defect. Because if the patient continues like this, a time would come that it will be difficult to get them straightened up completely. Then this is how the anticolis looks like. It has to do with the neck. So the neck kind of is flexed down. That's the position they assume. Also because the neck extensors have lost that strength to keep the neck up against gravity. But when they lie down, you see that the neck has assumed the normal position. Then we have the PISA syndrome. The PISA syndrome is lateral flexing. It's lateral flexing. And as you can see, this is how it looks. Even when they are seated in a chair, you see them tilting towards one side. The difference between this PISA syndrome and scoliosis is that when you take an X-ray with the scoliosis, you see that C kind of curve in the spine. But with this, it doesn't take that C shape. You see the whole spine tilting towards the affected, the side that is bent. So it is not just at a specific section of the vertebral column, but it's the entire vertebrae that you see slants to the side. So still on the motor assessment, we now look at assessment of a hand and then arm. Writing issues, as we indicated earlier, fine motor movement becomes an issue. So you can ask your patient to write for you to see. And usually we assess the writing with making this spider web circle. And as you see, this is for a healthy person. And then what is below on the side is for the Parkinson's. You see this zigzag in the circle, and that tells you that there is certainly a problem with the writing. For someone who will have to sign his or her checks and all that, this is very, very important for them, and it has to be dealt with. Then I have throwing and catching. Yes, this actually has to do with the patient's reaction time. If you've ever done this activity with a person with Parkinson's, you realize that they have a slow reaction time to something that is coming. So you throw, and before the hands come up, the ball had fallen. You have to do a number of times before they are able to get the rhythm of the movement, and then to, okay. Now, balance assessment. There are so many ways that we could do this balance assessment. We have the push and release, or the pull test. Parkinson's, we mostly want to do the pull test. If you want to push and release, there should be someone standing in front of the patient to catch, should they be a fall. Yeah. But if you do the pull, the patient is in front of you, and then when you pull them towards you, you will give them room to take steps to recover from the displacement you have caused them. And like I always say, you should be ready to catch the patient should they not be able to keep their balance. Then we can also use the back balance scale, the modified Parkinson's activity scale, the rapid 10 test, the dynamic gait index, the functional gait assessment, and the mini best test. All these are available outcome measures that one can use to assess balance. It's up to you to pick whichever is good for you, whichever you are comfortable with, and whichever is available for you to use. Okay. Okay, so assessment of gait pattern function and walking. Also, we have a list of outcome measures there that we can use. We have the 10-minute walk test, 10-meter walk test, 6-minute walk test. We have the rapid 10 test. So you see that some of the outcome measures can actually be used in two places. Okay. So when you administer one, you assess balance, you assess gait function pattern there as well. Okay. So assessment of mobility, including the risks of fall, we can use transfers. So this transfer from one chair to the other, modified Parkinson's activity scale, we can look at it from bed transfers. If the patient is in bed, how mobile are they? How are they able to move themselves from one point of the bed to the other? If it is chair transfer, are they able to transfer themselves from one chair to the other, from a wheelchair to another chair, or from a chair to a wheelchair? The 5 times sit to stand, the time up go test. All these are outcome measures that we can use to assess mobility, how mobile our patient is. Exercise capacity. As physios, it is exercise we'll be doing. So if your patient does not have the capacity to do that 10 times of the sit to stand, to do the stairs climbing, to do the treadmill walking, what do you do? How do you assess the capacity of your patient, even at baseline, before you give them the interventions? So the 6-minute walk test with the box measure of perceived exertion, rate of exertion, can also be used. And then the 5 times sit to stand can also be used. So this will help you to assess the exercise capacity of your patient as baseline. And then as you make progress, you can monitor the progress your patient is making in terms of their capacity for exercise. Now, screening for osteoporosis. This is not within our scope, but considering the fact that persons with Parkinson's are prone to falls, and if they have osteoporotic bones, it means the risk of fracture will be very high. So it is important that we consider this also as part of our assessment. But all this is about money. Tests will have to be done. The physio will not be requesting this, but if there is the need, always prompt. So when they go to their neurologist, they have these discussions. We don't have to wait for all the bones to become osteoporotic before we begin to deal with them. There are so many supplements that they can be given, and that will help build the bone capacity and prevent this osteoporosis or even minimize the impact of it. Assessment of activities of daily living. So we need to know how active our patients are, and the proposed tool to be used for this is the motor and assessment of motor and process skills is a tool. The Canadian Occupational Performance Measure as well can be used. The occupational performance history interview can also be used, and this will help us with more information regarding the person's occupational background and their coping mechanism. So I will have to switch because this laptop is running down. I have to switch to another one. Just give me a few minutes. I'll have to. Okay, I'll stop this from here. Okay. Please, pardon me. Please, can we see this? Okay.
Hello, madam.
Yes, sorry, I had muted myself. Okay.
Okay.
So sorry for that. The problem is that where I am to, there is doom. So at the moment, my lights are off and the computer I was using has run down. So I have to switch to another. So sorry about that. Yeah, let's make progress. So with the functional activities, I've already indicated the outcome measures that can be used. So this gives you more information about the person's occupational activity and how they are coping. Vocational assessment asks about difficulties in engaging work, employment, family roles, instrumental and advanced daily lives, domestic and leisure activities. And all this will give you the information you need about the patient's contextual factors that will also have influence on the interventions that you have to give. Okay, assessment of participation in community and social life asks about the person's participation. If the person is a Muslim, are they able to go to their mosque on every Friday? If they are Christian, are they able to go to church, attend other church activities? If there are any limitations or they are not able to do all these things as they used to do, then you need to find out why. And then that can also inform the kind of intervention you will give. Don't forget that education and advice are all part of the interventions that we give to our patients. So these we have talked about are more of OT focused. However, physios have a role to play in here. If you have an OT within your area, then with all these challenges, you can refer the patient to the OT so they can focus on all those specific employment and occupation aspects. But if you do not have an OT within your settings, then certainly you have to take this up and make sure that your intervention does not only end in the clinic, but translate into integrating the patient into their community and making them functional. We need to also know about family support. So there is an outcome measure, the Canadian Occupational Performance Measure will still work here for the carers. And then you interview the carer. We have other caregiver burden tools that can also be used to assess the level of burden that the caregiver is going through. And all this also helps to inform the intervention that you will be giving. So in summary, in conducting assessment on a person with Parkinson's, we do our subjective assessment first. The presenting complaints in the case of a person with Parkinson's, you get things like I move slowly or slow movement, shaking in the hands, difficulty with walking, and all other the cardinal point symptoms or the other motor symptoms that one can think of. When symptoms were noticed, you do the history of the presenting condition. You want to know the duration, how long has the condition been before them coming to you, the pattern of the presentation, where it started from first. And this will also tell you, are you really dealing with Parkinson's or is something else? Then their health-seeking pattern. This has to do with any previous interventions that they have obtained before. You have to note that down. Then their past medical history, you note that as well. Drug history should be previous and current. Yeah, any medication the person has been on in previous time that they are no longer on, we should note that. And then the current ones, plus dosages is very important. So you can also monitor their drug history as time goes on. Family and social history will focus on the contextual factors. History of symptoms in the family life, where they live, their environment, if it's compound house, self-contained, enough space. I remember those days we had one patient who comes for treatment, and by 6 o'clock, when I get to work, she's already there. So she's always the first person to receive treatment. However, she will be the last person to leave the department. Very, very sad. So one time I asked why, because I've finished treating this woman. As I go out, I come in, I see her still sitting there from about 9 a.m. in the morning. As at 2, 3, she's still sitting there. Why? She says where she lives, she will not be able to drive to the front of her house unless around 5 o'clock. That's the only time she can get closer to the house. Other than that, she will have to drop somewhere far and she will not be able to walk to the house. So all these are dynamics that you need to find out. I know some of them, as a physio, you may be limited in your ways of advice, but it's very important to note it. Yeah. So if the patient begins to put up some behaviors and they are not regular with their physio appointments and all that, it tells you that, okay, this could be one or two of the reasons why this is happening. Then you can address them. Any information on history, investigations that have been done, scans, and any lab tests that are relevant to us. So we are not talking about the long list of regular lab tests that they may have done, no, but relevant things. So if the person has done a CT scan, an MRI, an ultrasound, yes, those are vital information that we need. Those CT scan MRIs are not picking up Parkinson's for us. They will help us rule out all other problems. So with the objective assessment, as we have listed, your cognitive assessment, sleep, speech, voice, communication, swallowing, sensory functions, blood pressure, motor functions, functional activities, and then family support. So at the end, you would have conducted a neurological assessment that has focused on the person's cognitive and functional aspect. You would have looked at muscle tone, you would have assessed balance, you would have done assessment on musculoskeletal and motor aspects as well, looking at the muscle power or bulk, range of motion and gait, and then also you would have done functional assessment. And all this gives a holistic picture of the challenges that the patient presents, from impairments to activity limitations to participation restrictions to limitations within the person's contextual environment. So in conclusion, I will recommend you choose an appropriate assessment tool for each patient. I've listed a lot of them in there. All of them will not be appropriate for all patients. So you look at your patient and then you choose the one that is appropriate and safe. Safety is key for the patient. Familiarize yourself with specific tools for regular use. It is only when you use them regularly that it becomes easier for you to continue to use and it doesn't become a burden. However, there wouldn't even be any objective assessment if you are not using any kind of outcome measure to do so. A holistic assessment is always key for appropriate physical diagnosis and treatment. If you get the assessment wrong, you are likely to get your physical diagnosis wrong. You are likely to get your treatment or your intervention wrong as well. Design a suitable assessment sheet and incorporate the appropriate tools for completion. And when you do this, it helps you to keep a detailed, comprehensive, and consistent assessment of your patient. So you keep doing the same thing over and over because you have a structured sheet that you are completing for your patient, and you make sure all the relevant aspects to be assessed are there. The actions to be taken are also in it. And that makes assessment very easy, comprehensive, and detailed. So I want you to remember that if you don't remember anything at all that I have spoke about over this past 1 hour, remember it is never an objective assessment if you draw subjective conclusions. There should certainly be an objective conclusion to indicate your objective assessment you have done. Thank you very much for the patience and listening to me. If you have any questions or inputs or you need any clarity, I'm done. Thank you.
Thank you, Madam. That's indeed a detailed presentation. Let me start with the question myself. Please, madam, I want to understand PD patients not being able to sleep at night or overnight. Couldn't it be as a result of they sleeping more during the daytime?
Yes, that is one of the reasons that we attach. So when you interrogate your patient, they will come complaining to you that they are not able to sleep at night, but they will not be telling you that they are sleeping so much in the day. So you having all the knowledge about the condition will ask them, during the day, do you sleep? They are likely to tell you yes. And what's the duration that you sleep? They will say a whole lot of things that will let you know that they are doing so much sleeping during the day. And obviously, even in the absence of Parkinson's disease, when you sleep so much during the day, sleeping at night becomes a problem. So it's not just the Parkinson's that is causing the problem, though it has a cause with the excessive daytime sleepiness. So obviously, the plenty sleep during the day will cause challenges during the night for a person. So you now have to help them structure their day so they have an active day. If the day is active, the extent of sleeping will reduce, and then they will be able to have good sleep at night. The sleep experts advise that one develop a regular sleep habit. So if every day you are sleeping at 9, make sure at 9 you are sleeping. If you develop that habit, it becomes easier and improves one's sleep health. I hope this answers your question.
Yeah, thank you, madam. At this juncture, if you have any question, you can raise your hand up. I think we have a hand up from PT Lebene, if I'm not mistaken. Please, you can unmute.
Yes, I see her hand.
Yeah.
Okay, please unmute your mic and then.
Okay, good evening, everyone.
Good evening.
Hello.
Good evening. Good evening. Yes, I can hear you. Please go ahead.
Okay, so thank you for the wonderful presentation, our facilitator. You can always trust her to deliver. So thank you very much. And thank you to the organizers for being on time. You actually started on time, and then I really want to commend that, and I hope you keep it up, and then you go far. Now, my question is just simple. I have this patient, he's 93 years old, and he's already asthmatic. So day in, day out, you see him coming to the hospital, he's always on oxygen. Every week he'll come for that, always on oxygen anytime. He has his inhaler, he uses it most often. But when he gets worse, you see them rushing him to the hospital. Now, my question is, won't that probably affect in the subjective assessment, the point 4, the speech, voice, communication, and then the swallowing function? Because he also has the drooling, but just there's not much. When you're attending to him, you see something small coming out.
Okay, thank you. So if you remember, with the speech part, there is even an aspect of breathing rate in there. Because when you see that when you are exercising and you are doing strenuous exercise, speaking becomes a problem. To exercise like that, you need to breathe. And to pause and speak, it becomes challenging. And your ability to speak fluently or continuously determines even your rate of exertion when you are doing exercise. You can use that to determine the extent to which one is actually exercising. So now, coming to the issue, this patient has this asthma as a comorbidity in his condition, adding to the Parkinson's, though you have not mentioned his Parkinson's. Let me just assume that is Parkinson's. So
Yes,
there
he
is
is a Parkinson patient. Sorry about that.
okay, good. So this asthma comorbidity has added to the Parkinson situation. So already there are issues with breathing, which can automatically affect speech. However, the training with speech and all that is not within the scope of physio to do. If it is too much of a problem, you discuss with them and then you refer them to a speech therapist. That is if you have one in your facility. I know the speech therapists are also quite limited in our country. So if you have one, you refer. If you do not have one, then it means you have to give some level of basic advice as to how to improve his state, coupled with the exercise he will have to do. And once there is issue with breathing, we cannot run away from deep breathing exercises, which the patient must do religiously to help enhance his breathing. And then indirectly will help improve the sound of his speech as well. That is just the little that we can do from our side as physios, since we are not experts in speech therapy. Does this help, please?
Yes, please. Thank you very much.
Okay, thank you too.
Okay, please, if you have anything bothering your mind, you can raise your hand up. You can go to the reactions and you tap raise hand up and you'll be called.
Okay, so whilst we are waiting for any additional comments, I will want to show this screen, which is about the International Parkinson's and Movement Disorder Society. So this society is an international body for movement disorders, neurologists, researchers, allied health professionals. It has varied professionals in it, and the focus is all about movement disorders, which includes Parkinson's disease, making life better for persons with Parkinson's, improving knowledge for health professionals involved in the management of Parkinson's. Mr. Ajen, I'll call you briefly. So I will want to encourage you to join it. We as Ghanaians coming from a low middle income country, we do not pay to join this organization. We are described as no fee paying members. So if you go to the site and click on their link, you will be able to register to become a member. And when you become a member, you have access to a lot of outcome measures that are used for varied movement disorders. And then also opportunities for training that you can have in the use of these outcome measures. Opportunity for further training in the management of PD and other movement disorders. So this is my little encouragement here for you. I have been a member of this organization since 2014, and I have not regretted being a member. I have learned a lot. I've had a lot of exposure with them, and I'm very certain if you join, you will also learn a lot from them. So, Mr. Ajen, please, you can unmute yourself and speak. Hello. Mr. Ajen.
Yeah, hello.
Yes. Yeah.
Yeah, my question is, I want to know if there are any risk factors for Parkinson's disease. And also another question,
Mm-hmm.
Could there be a possibility whereby a Parkinson disease patients would have only motor symptoms without showing signs of non-motor symptoms.
Okay. Okay. Thank you very much. So with regards to the risk factors, yes, there are risk factors. Age in itself is a risk factor. So as one ages, your chances of developing Parkinson's is high. Family history of Parkinson's is a risk factor. Genetic predisposition, so that is where the family part comes in. Exposure to some environmental toxins. Paraquat has been named as one of those environmental toxins that when one is exposed to, you are likely to develop Parkinson's. So even though we do not know the cause of Parkinson's, the assumption is that there should be a genetic predisposition coupled with these environmental factors that trigger the degeneration of the dopaminergic cells. So these are some of the risk factors for Parkinson's disease. Now, coming to the issue of showing motor symptoms without non-motor symptoms, I may not be able to say yes or no, but if we want to analyze what exists in literature, that the degeneration, the dopaminergic cells do not only provide support or control the activities of motor performance in humans. No, the dopamine that is being produced also control some non-motor activities. And that is why the reduction or the lack of the dopamine within the brain cells can result in non-motor symptoms. So once there is a reduction in dopamine in the system, then it means that every other physiological function of the dopamine will be affected. And these non-motor functions are also being controlled by the dopamine. So certainly, one cannot run away from the non-motor symptoms. Yeah, but what we have to bear in mind is that patients are unique and individuals. It doesn't mean one patient will have to present all these non-motor symptoms that have been listed, or one patient will present all these prodromal symptoms that were presented, just as one patient will not present all the motor symptoms that we have presented. The cardinal motor signs are key. The bradykinesia plus at least one of tremor or rigidity should be present. There are some PD patients who don't exhibit tremors. It's just the slowness. And they are the most likely to be missed because they don't shake. But those with the tremor are easily picked up. I hope this helps answer your question.
Yeah, thank you very much.
Okay, thank you too. Yes, please, Manuel.
Okay, good evening.
Good evening.
Please, I would like to know if Parkinson can be prevented, or if there are ways that can reduce one from the risk of getting Parkinson.
Okay, thank you. So, if we look at the prodromal symptoms that we have, and then we look at some of the risk factors, it's only when you know what causes the problem that you say, okay, I will stay away from it so I can prevent it. But in this case where we do not know what is causing it, it becomes difficult. However, some of the predisposing factors, we can deal with them. For instance, exposure to this paraquat, which has been confirmed to be one of the risk factors. That tells us that if a farmer uses any pesticides or herbicides that has this paraquat in it, then they will have to stop using it. because if they continue using it and there is any genetic predisposition, then there is the likelihood of the person getting Parkinson's as they age. With the issue of age, there is nothing we can do about it. We will all age. So that is not a risk factor we can modify. So my simple answer to you is that it is difficult to say that we will prevent Parkinson's, because once there is a genetic component in there, the likelihood of one exhibiting Parkinson's is very high. So that is what I can say.
Okay, thank you.
You're welcome. Any other question? Or if anyone has an input? Michael.
Hello, madam.
Yes.
My question is not directly to the presentation, and I don't know if this is the correct platform. I want to know if you have any plans of extending the Parkinson disease support group to other regions, not only in Accra. I don't know if you have any plan of that. For Bruno Ahafo, I am willing to volunteer and partner with you. So I want to know if you have any other plans of extending it to other regions.
Okay. Thank you very much. This is a good thing. The last thing I would have said before we ended this session would have been that I'm open to research ideas. I'm open to case discussions. I'm open to anything related to what I do. My introduction said a lot of what I do. So anything related to what I do, I'm open to it. So this is a great proposal you have made. Starting or establishing these support groups are not that easy. Like I read somewhere that, yes, the support groups themselves need support. So if we establish a support group, what is the focus of the support group? With the Parkinson support group that I help coordinate, it was actually started by a person with Parkinson's with the support of family. Then when I got to know them, I decided to join them and support what they do with my expertise and help coordinate their activities. So a health professional can also initiate the support group, but there should be a commitment to want to support. There should be the need for funding, and all are things that we have to plan out and strategize how this will be done. So it's a great idea. After today, we can continue discussions on that, and there are literature and other things available to help start a support group. In Ghana, there are only 2, and we are trying to establish an additional one in Sogakope as I speak, to make 3 now. So if we have someone to shoulder and initiate one in Brown Ahafo, that is great. And moving forward, we can see how we collaborate to improve the support that we give to persons with Parkinson's in Ghana. So Ibrahim, that is welcomed. After today, we can continue discussion on that, and then we see how we start it out. Thank you. Yes, Lebene, I see your hand again.
Okay, thank you for the opportunity. I would like to ask briefly, has there been any research to look at the relationship between occupation and PD? Because way back, I had 2 clients that were bankers, and then they ended up suffering from PD, and then one unfortunately passed away last year. So I just want to know if there is a relationship between our occupation and then PD. Thank you.
Well, I think the a study directly looking at the relationship of one's occupation and PD, I have not come across such, but at least looking at exposure to some toxic chemicals and all that, they only looked at the chemicals. So by extension, if you work in an area that kind of predisposes you to those chemicals, you are likely to develop Parkinson's in future, though not everyone will get it. Then one other risk or predisposing factor is actually trauma to the head. So we always use Muhammad Ali, for example, in this case, that because of the boxing, there was so much hitting on the head and all that, and that could be his predisposing factor, maybe coupled with some genetic factors leading him to suffer Parkinson's disease before he died. So if we look at Muhammad Ali, then we will say that his profession predisposed him, coupled with genetic factors, to trigger his Parkinson's. But there are so many boxers around who have not suffered Parkinson's disease. Apart from Muhammad Ali, I do not know of any other boxer who has openly declared to be suffering from Parkinson's disease. I'm yet to get that. So maybe this is something else that we also have to pay attention to see if we can draw any link between Parkinson's disease and then people's profession. So this is another research topic that one can look at. Yes, so I see, forgive me, I'm trying to pronounce your first name, but I'm struggling. So let me say Miss Anaglate. That one is easier for me.
Okay, thank you very much for the presentation. The name is Viblimi Anaglate, or
Okay,
Vivli for short. If you want to first name. Yes, Viblimi or Vivli for short. And please, you spoke about Parkinson's disease support. You can get the link to that. I'll be very grateful. Thank you.
You said the link to what?
You spoke about the International Parkinson's Disease Support Group, about getting access to outcome measures.
Okay, so it is not a support group. It's International Parkinson's Disease Movement and Movement Society, Movement Disorder Society. That is what is showing on the screen right now. Yes, so this link, I can forward it to you. Just send me a hi on WhatsApp. I will send it to you.
Okay, thank you very much.
Okay, you're welcome. Yes, Nana Pearl.
Hello, everyone, and good evening to us all. I want to thank Mike and Ivy for such an opportunity to refresh our minds on the subject matter. What I want to ask is, what causes the loss of dopamine? That's my first question. Is there any factors that's contributing to the loss of dopamine, which is, I think, the main, I don't know whether it's the cause or maybe a risk factor of people getting this PD condition. Secondly, my question is a little bit different from what we are discussing, but I would like to get Madam Mary's input or her suggestion or views. I have this 34-year-old client with CVA. She was admitted at our stroke unit, was discharged, had rehabilitation. She gained her strength. She's now moving now, very active and all that. However, her issue has to do with, she says she needs to be back, like get everything back originally, like how God created her. She wants her powers in her hand back and everything. So from my discussion with her, it seems she's still in the denial stage. as in she still doesn't believe she's having the condition and that she's praying to God for God to give her divine healing. Fast forward, I helped her book an appointment with our neurologist here. And this girl told me that how can she get past the OPD without anyone seeing her? And that she doesn't want to be seen by a familiar person, like seeing her in that condition. So as it stands now, I really don't know the kind of help I'm to offer this girl. I've talked to her and trying to get her to understand the condition in which she is and also see how best she can optimize the condition and also go about her daily lives. But this is a girl that is still being adamant despite all that I've done, all my inputs. So I would like Madam Mary to also help me if she's faced with such a patient. I don't want to say she's difficult, but if she's faced with such a patient, how does she go about helping her? That's my submission.
Okay, thank you, Nanapo. So the first one, that's about the degeneration or the loss of dopaminergic cells. So what causes the reduction in dopamine is the loss of the cells, because it's the cells that produce the dopamine within the brain. So if cells reduce in quantity or in size, certainly the output of it is also going to reduce. And like I said earlier, risk factors will predispose one into this dopaminergic cells degenerating. As to the exact thing that is causing this degeneration, that is what we cannot place our fingers on when it comes to idiopathic Parkinson's disease. All we know is that the dopaminergic cells are degenerating and they reduce in number, they reduce in size, and the amount of dopamine that is produced also reduces. And then we begin to see the symptoms that come with the reduction in the dopamine. That is it. So we have genetic factors being fingered in this. We have environmental factors, like I mentioned, even the trauma to the head. We have exposure to toxic chemicals. I mentioned the paraquat that we have always mentioned in this situation. Yeah, so these environmental factors coupled with any genetic predisposition triggers the degeneration process. And we don't know when it's what causes that to happen. Yeah, so that is what I have to say about that. Like someone asked, how do we prevent it? Unfortunately, we don't know. Then how then can we prevent? We know when you are bitten by mosquito, you will get malaria. So if you sleep in the mosquito-treated nets, you will not be bitten by malaria, by mosquito for you to get malaria. Unfortunately, in this case, we are thinking that trauma to the head can trigger this degeneration, but we are not even sure. Yes. Now coming to your second question or scenario about this lady. Yes, she's young. In lay terms, you will say, oh, this is a difficult patient, but not difficult. There are challenges. This person might be depressed. This person is anxious about a new situation. You say she's 34 years, if I got it right. 34 is quite a young person. I do not know if this lady is already married. I do not know if she already has kids or she has that family support. And all these things, you have to address them. I don't know whether she's employed or not. And in her current state, is she still working? And if she's not working, what is the problem? Yes, Nana, you want to answer?
Yeah, I think I left out the social history. So she is a teacher. She used to have a boyfriend, but since the conditions set in, I think they are no longer in a relationship now.
Okay.
And she has a very good family support.
Okay.
All the siblings are rallying behind her every time they bring her for therapy and sessions.
Okay.
But currently, I've not seen her. And she used to transit between Accra and Asamankese. She goes to live with her sister for some time and comes back. And in Accra, she told me when she's exercising or moving out, because not so many people know her there, she's able to exercise. But when she comes to Asamankese, that's where the family resides. That place, you can't really exercise because a lot of familiar faces are just around that place. And since the condition settings, she's not been able to go to work. So right now, this is the challenges she's facing now.
Okay. So per your assessment with her, do you see her as a capable person to resume work? The teacher.
Well, yes, I see her that she can. However, she is not willing to go.
Okay.
Yes.
Okay. So
yes,
maybe we will have to continue the discussion with this lady outside this presentation, so I can find out further information on her, and then we see how best we can help her. Yes.
Okay, that'll be fine.
Yeah.
Thank you.
Okay. So kindly get in touch so we can have further discussion on her. Okay.
Okay, that'll be fine. Thank you.
Yeah. Thank you too. Please, any other input, question? Yes, Equia. Hello, Equia. Please unmute yourself and speak.
Can you hear me?
Yes, please.
Good evening.
Good evening.
Thank you for the presentation as well. Very informative. So just to build on, okay, if I would say something on the stroke patient, then come to my question just a little bit. So acceptance of disability, it's an issue with stroke patients. And also he didn't give us the time frame, how long post-discharge the patient, how long is it now post-discharge? So that would also help us understand where she's at and what she can get in the future. All right. So now back to the PD patients. So do they also have these issues, the psychological issues, or for them, because of the cognitive involvement, they really don't have a lot of emotions or emotional reaction to the condition? So that's my question. Then the second one would be, you see the rigidity and the tremors. Sometimes you might have similar presentations with the stroke patients. So is there a differential, or is there a very accurate diagnostic tool, or how do I put it, just to identify that, okay, this is not this is not stroke, it's rather PD? Because at our facility there was this elderly man, we knew it was PD, but you refer to the doctors, they bring him back telling us that it's stroke. So it's kind of difficult to actually now, okay, the doctors, they would always go like, oh, we've done everything and it looks like it's a stroke. So how do we handle that, or how do we really draw out our diagnosis physically without even an investigative diagnostic investigation?
Okay.
Yeah, so these are my questions. Thank you.
Okay, thank you very much. So starting with the first one, which has to do with this state of denial. Yes. When we look at the presentations and the patterns of disability that come with these neurological conditions, they all can't run away from this state of denials. Just that the stroke thing becomes more obvious because stroke is quite sudden. So I was walking yesterday, today suddenly I cannot walk. And that makes the problem very prominent, and it becomes so difficult for them to accept their state. However, Parkinson's is not immune to this kind of problem. Persons with Parkinson's also sometimes have these denials that I don't think I'm the one suffering this condition. No. But the only thing that helps these people is the nature of how the condition begins. Because it creeps in gradually, you come to the realization that, oh, there is something wrong with me. Okay, you pick it up, you take steps to address it. You are still going to work. You are doing your daily things gradually. Then you get the diagnosis. Okay, this is what it is. It's not going to be cured, but we can help manage it. With education, most of them are living well with it. Most of them are living well with it. And then also because it's something that majority are the elderly, they're already grown. So some too would tell you that, well, I think I've lived my life. I remember one patient telling me that he's in his extra time in life. So if he dies even today, he doesn't care. His children are worrying themselves by wanting him to do physio and all that. Yes, so once it's a neurological problem and has to do with the brain, these cognitive issues cut across either stroke or Parkinson's, but it is individualized. In Parkinson's, it's very, very much individualized. We have those who are very optimistic that, okay, I embrace it and I see how best I live my life with it. We have the others who will continue to be in a state of denial, like the patient I described that he says he has worked all his life. Now he's retiring to go home rest, and suddenly he's being hit by this condition, and he doesn't want to accept it. I invited him several times to the support group. He came once or twice, and that was it. You call him, he doesn't come. Even physio, he doesn't come. We still try to follow up, but it's difficult for him, it's difficult for us too. So that is it with the cognitive bit and the state of denial bit. I would say it cuts across, and we just have to manage them individually. I see your hand up again.
Sorry, I've not put it down, so ignore
okay.
it.
Thank you. Then now moving on to the state of stroke symptoms mimicking Parkinson's, or now we say Parkinson's symptoms mimicking stroke. Which is which? Okay. So the first time I saw Parkinson's, aside what I read and saw in book, was a stroke patient exhibiting Parkinson's. That is the diagnosis that we handled. Unfortunately, the patient passed before I got enough knowledge to let me know who a person with Parkinson's is. So as of today, I can't tell what exactly was the patient's condition. But if I could scan very well in my mind and picture this patient very well, I would say it was Parkinson's, but not stroke. So when or what will help us determine that, okay, this is idiopathic Parkinson's disease and not vascular Parkinsonism. It is vascular Parkinsonism when the person suffered a stroke and then later started exhibiting signs of Parkinson's. Then that becomes vascular Parkinsonism. It is not idiopathic Parkinson's disease. However, if it becomes difficult for us to tell whether it is Parkinson's or it is stroke, can we pay attention to the pattern of the condition? When it started, how it progressed. We all know how stroke starts. Stroke is sudden. It comes and hits one time. Stroke doesn't occur over a period of days. No. So if this person is exhibiting obvious weakness on one side, and that is the other thing that causes the confusion, because Parkinson's begins unilaterally and progresses to involve the other side, at always one side appears weaker than the other. Only on few occasions that it becomes very difficult to tell which side is weaker and which side is stronger. But on most occasions, you realize that one side is weaker. And when you interrogate the patients, you realize that the weaker side is where the symptoms first showed up. So if we are confused, let's go back to that genesis of the symptom. When did it start? Was it a sudden occurrence, or you felt the weakness gradually over a period of time before you visited the clinic? With all these details, we will be able to make that concrete decision or clinical decision that no, this is not stroke, it is Parkinson's disease based on the mechanism. So if you ask, this is how I will put it. The mechanism of the development of the condition should be able to help us to differentiate between vascular Parkinsonism and idiopathic Parkinson's disease. And if you make this case, you state it out clearly and make that case, any doctor who knows his facts will accept, because when he goes back into the books, he will realize that what you have put out is correct. I encountered a number of cases like that when I was in Kolebo. They come in with a referral of stroke because obviously you see that one side is weaker and the other side is stronger. But when I carry on my assessment, I ask all these questions, I'm able to draw that clinical conclusions that no, this is Parkinson's disease and not stroke. Then I refer the patient to our neuro clinic so the person can have that final diagnosis and then be properly managed as a person with Parkinson's. I hope this helps answers your question.
Yes, I think it does. I think you made it very clear now.
Okay.
But a follow-up to that now would be, so the vascular PD, are we managing it the same as idiopathic PD? Is the management the same?
When it comes to management, we will not even say the same management for two idiopathic PD patients. So the same principle applies when it is vascular Parkinsonism. We look at each patient as an individual and assess their own impairments and functional limitations, and then prescribe appropriate interventions that will deal with their problems. So that, our intervention is not like when it is malaria diagnosed, you give artesunate amodiaquine, 5 milligrams or 100 milligrams. Our own isn't like that. So even two PD patients can be presenting the same problem, but the same intervention will work for both of them. For instance, you have two patients presenting freezing of gait. Then we have cueing. We have visual cue, we have auditory cue. They are both interventions. Auditory cue might work for one, but it won't work for the other. So we always look at the patients as individuals and see which intervention will work for them individually, and then we administer that. I hope this also helps.
Yes, please. Thank you very much.
Thank you very much too. Okay. Yes, Francis.
Okay, I think this should be our last question for the
Hello,
day.
madam.
It's getting interesting, but we have to respect time. So I think this should be our last question for the day.
Okay.
Hello, madam.
Yes, please. Yes, Francis. Please go on.
What Madam Mekuya urged.
Yes.
My question is, if you are treating a patient with both conditions, what will be the physio intervention towards that patient?
Intervention. Yes, it
please.
still comes down to the individualization of every patient. Physio has varied interventions. So if we look at just looking at Parkinson's, physiotherapy interventions in Parkinson's. Today is not about interventions for persons with Parkinson's, but if we are to look at interventions for Parkinson's, we have a lot of them. So it's not about, okay, a person with freezing of gait, use cueing, use visual cueing. Like I said, Mr. A, visual cueing will work for Mr. A's freezing of gait. Mr. B also having freezing of gait, visual cues won't work. So if you have a plethora of interventions, plenty of them, you have your patient, you have done your assessment, you have the functioning problems that the patient is presenting, you have listed them. You now go into your set of interventions. Okay, which intervention would deal with the muscle tightness? Which intervention would deal with the balance problem? Which intervention would deal with the PISA syndrome, the lateral tilting that the patient is exhibiting? So you now look at your set of interventions and pick which one you think might work for that situation. You apply it because already there is literature to support that with freezing of gait, cueing will work. But you will now have to administer auditory cues to your patient to see if that will work for him or her. If it doesn't work, okay, can we go for visual cues and see if it works? If it works for him, that becomes his intervention. Francis, I hope this helps.
Yes, madam.
Okay.
Thank you so much.
Sure. Thank you very much to all of you who have been able to stay up till now. I know some have fallen off. I'm very grateful to Michael and his team for giving me the opportunity to also share my knowledge with you. It has been a very interesting session. I'm happy myself. I hope you have also learned something to help improve your practice and skills. So my last words, if you have any further questions, kindly reach out to me. If you are on our Physio platform, my number is not hidden there. I'm always there. Just get in touch and then we can further discussions to improve the services that we provide for our patients and help improve their quality of life. Thank you very much. So I hand it over to our moderator.
Okay, thank you, Madam. At this juncture, I'll call on Michael to give us the closing remarks.
Thanks very much for staying with us throughout this section. We will entreat all of us to try as much as possible to subscribe to our channel. And also you can follow Madam Mary on LinkedIn. Let's try and follow her on LinkedIn as well. LinkedIn is a very good platform, and as physical therapists, it's one of the ways we can use to improve our practice. Thankfully, I've had the opportunity to receive a certificate from the International Parkinson and Movement Disorder Association based on the motivation given by Madam Mary. I've also joined the Parkinson UK. All of these things are based on her motivation, which was indirectly, and I appreciate her for that. We hope to bring education to our doorsteps and make it more easy, because as physical therapists, we really need to advance our practice, and there is no doubt about that. Finally, I want to say we thank you, Madam Mary, for having the time to share your knowledge. And upon reflection, I was able to deduce two meanings from what I've learned from him. I stated it on my status that knowledge will humble you, and the only pleasant thing that can humble you is knowledge, and the only unpleasant thing that can humble you is sickness. We've really learned a lot from you, and we hope that we will call you next time, and you also share whatever you have, maybe on stroke or something. So once again, thanks very much for coming. This is Icona Health and Research Consult. Have a blessed evening.
Okay. Bye-bye, everyone.
Bye-bye.